Our next speaker is Dr. Sima Das. She is an oculoplastic surgeon, and ocular oncologist in Delhi, Saraf Charitable Eye Hospital. Dr. Sima, please.
Thank you, Dr. Chandanan. Thank you for this opportunity, and it has been, great learning to look at all these interesting cases. So we have already kind of, discussed about the diagnosis, the various mimickers, and how to handle the tissues. So the next part is how to manage these cases. So I'm going to talk in brief about how do you go about managing the patients. So again, when we talk about managing any periocular or eyelid malignancies, we need to know about the type of malignancies, and we have seen already there can be various types. Most commonly, we have the three types of malignant eyelid tumors, the BCC, SCC, and the SGC. We need to know the extent of the disease, whether it is just involved or confined to the eyelid, or whether it has gone beyond the confines of the eyelid to the orbit. We need to know the systemic status, so do a good metastatic workup. We also need to know the systemic profile of the patient and whether our intent of our treatment is curative or we are just looking at palliation depending on the extent of the disease. So these are all the things which are going to help us decide how we approach these patients. So again, just to recapitulate, many times when we do a biopsy, sometimes you go for an incision biopsy and sometimes you go for excision biopsy. For example, in scenarios like this, what do you think this is? Dr. Anirban and Dr. Fairuz has already mentioned about, what are the red flag signs. So looking at all the parameters, where do you put it? Do you think it's a benign lesion? Do you think it's borderline malignant, or do you think it's frankly malignant? He's a young guy, couple of months of history. So it looks like a little angry looking vascular lesion. There are some telangiectasia. There is loss of eyelashes. The lid margin seems to be involved. So we lean more towards sort of, malignancy, but we can never be sure. It's a small lesion. Now, if you have to biopsy this lesion, what are you going to do? Are you going to take an incision biopsy to confirm your diagnosis? You are going to excise it completely. You are going to do a shave excision. What should be the plan? Same for the, the second lesion. So in smaller lesion like this, where we know that we are leaning more towards malignancy and we know that this can be easily excised with a margin also, and we can easily reconstruct the eyelids, it's better to go in for a full thickness excision. With presuming that it's a malignancy, you can also take the margin. So this did turn out to be a malignant tumor, apocrine sweat gland carcinoma of the eyelid. And then we could do a direct excision at the first go itself, pentagon excision. So it was just one sitting of surgery for him. So in lesions which looks clinically pretty highly malignant, which are amenable to complete excision without any major surgery, it's best to go for excise. That itself becomes your incision biopsy, and then you go for the histopath. These lesions, Dr. Chandana has already mentioned that the base of the lesion is very important. These are cutaneous horns. Sometimes it might just look like it's a benign looking thing. Especially the first one was actually a small skin tag with some horn, but the second one was not. There is a base to it. So again, in this kind of situation where you feel, again, you're not sure whether it's benign, completely excise it or incise it. Even if you're planning for a debulking sort of lesion without taking any margin, it's important to focus on the base at the histopath. If the base turns out to be malignant, then you have to go back and sort of, excise it completely, taking again 4 millimeter of your margins. Now, these are the three most common malignant eyelid tumors, and we know that the primary treatment for all the malignant eyelid tumors of the eyelid remains a complete surgical excision with a margin clearance. Dr. Fairuz has already emphasized on it. I'm not going into the details. 4 millimeter margin is mandatory. If you have a frozen section control, fair enough. Otherwise, you go by clinical margin, assess the margin histopathologically, make sure it's clear before you go ahead and close the defect. And if the defect is small, where it is amenable to close with a direct repair of the lid margin, you go for a pentagon excision and a direct repair. Sometimes it's not possible to close it directly because the patient might be young, the eyelids are not very lax, or the defect is little bigger in size, so you can do a transposition or a local advancement flap. Like here, it was closed with a Tensel's flap because the defect was slightly bigger. And if the defect is even bigger, especially if it's an upper lid defect, you can go for an eyelid shearing procedure. These are all the procedures which we are going to do after you are sure that you have taken care of the disease and the margins are clear. So this was a cutler beard. If the canthus is involved, which sometimes can be the case, it could be an isolated canthal lesion involving part of the eyelid also. Like this was essentially canthal involving the medial upper and the lower canthus both. And so we know that the canthus is going to be sacrificed here along with the part of the eyelid. So you have to ensure that you reconstruct the canthus also, because these are the pillars for the eyelid, and we have to remember the basic principles for reconstruction of the eyelid. Sometimes we need a combination of flaps depending on whether the anterior lamina itself is involved or it is anterior plus posterior lamina on the canthus. So this was anterior lamina, posterior lamina, as well as part of the lateral canthus. So this was taken care of with an lateral periosteal flap along with a tarsoconjunctival flap for the posterior lamina and a skin graft for the anterior lamina. So there are various combinations which you can use. Like reconstruction is, there is no set rule. It depends on, what you prefer, but all you have to do is to remember the basic principles. First principle is ensure the disease is gone. Second is we ensure that the anterior lamina, posterior lamina is taken care of, and the functional aspect of the eyelid, the lid closure should be adequate, and the movement of the eyelid should be adequate. The corneal protection should be taken care of. So if these are the principles we follow, we can then decide what are the flaps and the grafts which work best in our hand. Medial canthal defect a little tricky to repair. But again, after excision, it's a fairly big defect, almost 2/3 of the upper lid, full thickness gone. So we can do again a combination of flap, a glabellar flap, along with the cutler beard with a local periosteal flap can be used to take care of both the lamina, like this. And again, it's a 2-sitting procedure. You have to divide the flap later on to open up the eyelid. An isolated medial canthal lesion, again, which is essentially involvement of the anterior lamina, you can go ahead and manage with maybe just a excision of the anterior lamina and then covering the defect with a skin graft, again ensuring that there is a margin is clear. Now there are situations where we know the patient needs a surgical excision, but the lesion is so big that these are not amenable to surgery. Now this was a biopsy proven sebaceous gland carcinoma which has gone from the eyelid to the orbit, and if you see the extent, it is going right till the posterior orbit. There is no way you can excise this lesion even if you do an exenteration and get a clear margin. So what do we do in those situations? So what we do here is give a neoadjuvant chemotherapy. And we know that it works pretty well in sebaceous gland carcinoma. There are enough evidence now to show that, and sometimes it shrinks the lesion to the extent that you might not be needing a destructive surgery also. Like in this gentleman, we can see the proptosis is gone, almost the lesion is cleared up anteriorly, and many a times it might be possible to just manage it conservatively with some post-op radiation post-chemotherapy also. Again, depends on the residual lesion. So locally advanced HGC which are not amenable to surgical excision, you can chemoreduce them and then plan your definitive treatment. Sometimes we know that it's a frank malignancy, but if you are planning a destructive surgery, like in this situation, there is no doubt about the diagnosis. But again, just to get a confirmation, because we'll be planning an exenteration for him, you might have to go for an incision biopsy. So other situation where you go for incision biopsy, Dr. Anirban already mentioned about it, the pagetoid variant of sebaceous gland carcinoma, which can present like a diffuse blepharoconjunctivitis without any visible eyelid mass, where you don't know what is the extent of the tumor. And when we do a biopsy here, what we do is something known as MAP biopsy. Why we do a MAP biopsy? Because depending on the extent of the conjunctival involvement, we are going to decide what treatment we are going to offer to the patient. So if the MAP biopsy is positive for say more than 2 to 3 quadrants, we know that we won't be able to excise this lesion and make a kind of functional ocular surface. So in those situations, many a time these are the patients who go for exenteration also. But if it's localized MAP biopsy positive less than 2 quadrants, you can plan for an excision and then reconstruction of the ocular surface, and associated involvement of the eyelid can also be taken care of depending on the extent of the lesion. Now, other situation where we know the patient needs an extensive surgery, it's an eyelid tumor, malignant eyelid tumor, where surgery is the primary treatment modality, but the patient has systemic comorbidity. Like this gentleman, he's an elderly gentleman, more than 80 years. He is on chronic renal failure. His creatinine was more than 5. He's on weekly hemodialysis. He has ascites and multiple other systemic comorbidities. So there is no way the anesthetist is going to give you a fitness for an exenteration, which is a long surgery. But he did need some sort of treatment. You can't give him chemo also. So what are the things you do for these situations? By the way, if you see his eyelid margin is barely visible, the eye is still there. So this is a lesion which has eroded the upper eyelid, gone till the eyebrow and gone till the anterior orbit also. So we had to take up this patient actually under local anesthesia, under some sedation, whatever possible, kept on talking to him, try to do a sort of excision as much as possible with the visible margins, and then reconstruct the eyelid with using a median forehead flap. So idea is there, that you might not have taken care of the whole extent of the disease, but even if you kind of give him longevity for about 2 to 3 years more where the recurrence does not happen, so I think that's what the family was looking at. And if you can add up some post-op adjuvant radiotherapy, that it might even kind of reduce the recurrence rate further. Some other situations where again these are going to be surgical excision, but the surgery is going to be so extensive, it is going to be cause a lot of deformity of the face. The patient is going to lose the eye. So the option here is to sometimes give, post radiation therapy, which we know sometimes for extensive BCC, it works pretty well. It could be a palliative attempt if the tumor has already gone beyond the confines of the face, but more often than not, it works pretty okay. And since it's a very slow growing tumor, the idea is to arrest the growth of the tumor. It can avoid disfiguring surgeries. So just the last bit, sometimes there are situations where you do a biopsy thinking that it's a malignancy, but to our surprise, sometimes it turns out to be something else. So what do you think this could be? It's a very irregular looking thickening of the tarsus, but it's not yellowish, it's more whitish, it's waxy. So does it strike anything? Does it look like anything? So this was a conjunctival amyloidosis, which can mimic sometimes a malignancy. There are hemorrhages sometimes which keeps on happening within the lesion. It can cause thickening of the tarsoconjunctiva. But again, here the biopsy is going to give you the diagnosis. And since these are not malignant, you don't have to do anything about them. And many a times we'll end up with other masquerades, like any guess what the first one could be? On the everted eyelid, it's again yellowish, tarsus is thickened. Do you have anything else in mind? SGC, of course, remains a differential diagnosis, but it was not an SGC. Can you think of anything else here? So this was actually a conjunctival tuberculosis, which was involving the conjunctiva, part of the tarsus. Biopsy proven it is not a malignant lesion. All you have to do is to treat the tubercular lesion here. The second was actually a patient of Hansen's, the leprosy. He had a periocular swelling, erythema, redness, but it was not again a malignant lesion. So those are the things we have to keep in mind. And in situations like this, where the tumor has gone beyond the confines of the orbit, gone to the pterygopalatine fossa, infratemporal, and this patient also had an intracranial extension, you know that you can't do much. There was a systemic mets also. Essentially, the treatment remains a palliative to give some comfort to the patient. So that was about in a nutshell how we approach this patient. Thank you.
Thank you, Dr. Sima. It was an